Hello and welcome to our webinar on building resilient health systems through faith-based organizations for improved health outcomes. My name is Matt Hackworth. I'm Director of Communications with IMA World Health in Washington, D.C.
Yes.
IMA World Health is a global faith-based ecumenical nonprofit that works with communities to overcome their public health challenges. And I'm pleased to co-host this webinar on behalf of CCIH, Christian Connections in International Health, a membership organization founded in 1987 to promote international health and wholeness from a Christian perspective through information sharing, networking, collaboration, and partnership building. A couple of housekeeping things to look at before we move into our webinar, just to let you all know about the flow here. Of course, we want to welcome you to the webinar and let you know that all attendees are on mute. We also want to let you know that the program will last just about an hour and include a time for questions and answers right at the very end of the webinar. We also want you to know that you can ask your questions using the GoToWebinar control panel over on the right side of your screen, and we'll take those questions using the chat feature. So as we progress through the webinar, if you have a question that you want to ask the panel, feel free to note it down in that chat window and send it to us, and we'll get to it right at the very end. Also, just to let you know, there will be a recording link available of this webinar, and we'll make that available just as soon as we can. We like to say a couple of days or so, hopefully within the week. Joining us today for our webinar are some very distinguished guests. We have, excuse me there, Peter Yeboah with the Christian Health Association of Ghana. Peter, good morning.
Yeah, good afternoon.
Good afternoon for you, actually. Thank you. That's right. Peter joins us from Accra. Also on the line we have Tonny Tumwesigye. He's joining us from the Uganda Protestant Medical Bureau in Kampala. Tonny, welcome. Tonny, if you're speaking, you're on mute, my friend. So if you could unmute your microphone so we can hear you, that would be great. Also joining us is Theresa Nyamupachitu here in Washington, D.C. with me at IMA World Health headquarters. She is one of our health system strengthening advisors. Welcome, Theresa.
Thank you, Matt. Good morning, everyone.
And Tonny, can you hear us now?
I can hear you loud and clear, Matt.
Excellent.
Good
Thank you so
afternoon
much.
from Uganda.
Great. Thank you so much. I appreciate you being here. Just to start off, Tonny, let's start with you. If you could give us just a brief introduction of the Uganda Protestant Medical Bureau.
Thank you, Matt. The Uganda Protestant Medical Bureau is a national umbrella organization for Protestant faith in Uganda. We've been around from 1957, basically formed by the Anglican Church and the Seventh Adventist Church, but we serve as a technical arm of these churches. We also provide support for other Pentecostal churches. The Protestant Medical Bureau oversees 291 health facilities, and these are scattered across Uganda. Under these facilities, we have 18 hospitals, 10 health center 4s, 56 health center 3s, and 200 health center 2s. These are basically categorizations within the national health structure, looking at hospitals all the way to the clinics. About 15 health training institutions also consist our network, and these are training institutions mainly for health workers, so health nurses and laboratory. The PNFP sector in Uganda is providing care of about 40% of the sector, and within these, we cover about 45% of all hospitals, beds, and 20% of the lower level health facilities. Faith-based network basically composed of the Catholic Medical Bureau, the Protestant Medical Bureau, the Muslim, and the Orthodox. But just to unpack that a little bit is that the Protestant Medical Bureau provides care for about 40% of this faith network in Uganda. That's just about the background of the Protestant Medical Bureau. Thank you.
Thank you, Tony. I appreciate your sharing. Peter, we'll come to you next. Peter Yeboah of the Christian Health Association of Ghana. Unfortunately, I don't have your slides available, Peter, but if you could just describe in general terms a little bit about the size and scope of the healthcare that the Christian Health Association of Ghana provides.
Yes, great. And thank you very much. CHAG, the Christian Health Association of Ghana, in a nutshell, is a coming together of about 25 different Christian church denominations. And it is composed of about 291 health facilities and health training institutions. And we are primarily set up to provide health services, comprehensive health services, especially for the poor, for the vulnerable, marginalized, underprivileged, and deprived segments to the society. We are located in all, particularly in the remote areas. And in terms of service delivery, we provide curative, preventive, promotive, and rehabilitative services across the country. CHAG assumptively provides between 30 to 45% of health services in Ghana. And that makes us an important partner, the largest provider of services apart from government. We are the second largest provider of healthcare in Ghana. And that provides us some level of leverage to enable us to play an active part in the health sector. CHAG generally, we are known or highly respected for influence in national health policy formulations all over. And with our 291 health facilities dotted around every part of the country, we are poised to provide healthcare. And come next year, CHAG, which was established in 1967, will be celebrating its 50th anniversary, that's Golden Jubilee. And we look forward to inviting all of you to partner us to celebrate the achievements, the challenges we've had, and prospects for our future. In a nutshell, that is CHAG. Let's forget, last year, as of 2015, we provided care for, we had about 6 million outpatient visits, 455,000 admissions, and we had overall student intake in our health training institutions of about 2,491. That is CHAG in a nutshell.
An important nutshell it is. Thank you so much, Peter. I appreciate you sharing with us a little bit about CHAG. Moving on, let's turn now to my colleague, Theresa Nyamupachitu, here with IMA World Health to talk a little bit about our role in providing health care across Africa.
Thank you, Matt. So IMA, as you have heard before, is a US-based international NGO. We were founded in 1960 by 6 Protestant mission organizations. And so we do have faith-based roots. Our vision is health, healing, and well-being for all. And our mission really is driven towards building healthier communities. And a key element of that is through collaborating with key partners to serve vulnerable populations. Amongst our key partners include ministries of health, obviously, international and local NGOs, as well as faith-based networks, which include Christian health associations and their regional platform known as the African Christian Health Association platform. So over time, since 1960, IMA has evolved. We started off in 1960 primarily serving procurement and supply chain support for our mission organizations, for their counterpart organizations in Africa. And then around 1993, we expanded our scope to include project implementation, primarily of neglected tropical diseases. And we saw first opening of a field office in Tanzania. And then today we have a broad scope of projects and activities ranging from neglected tropical diseases, HIV and AIDS, non-communicable diseases, nutrition WASH, as well as health system strengthening, which we're talking about today. We are in 6 countries that include DRC, South Sudan, Tanzania, Kenya, Indonesia, and Haiti, and we're also implementing global projects. On health system strengthening specific, IMA is implementing 2 projects in fragile states, particularly that is DRC and South Sudan. And that slide shows you, just gives you a snapshot of where faith-based organizations, or the magnitude of work that where faith-based organizations are implementing health system strengthening work. IMA has been working in DRC since 2000, and in support of the 1982 to 1987 Ministry of Health health plan, which decentralized the health systems into health zones, we have been we have been supporting provision of services of up to 75%. Right now, our main project around health system strengthening in DRC is called the ASSP project, which is funded by DFID, and IMA is working very closely with 8 partners, both local and international, where we're supporting 56 health zones in 5 of the country's 11 provinces, which include Kasai, Maniema, Equator Oriental, and South Kivu. In South Sudan, IMA has been working in South Sudan since 2008, supporting various initiatives. And what that map shows really is how the South Sudan has been divided to be supported by different donor agencies. In 2012, the Ministry of Health launched a new national primary healthcare program, which realigned donor agencies for primary healthcare support to work in specific regions. And you will see the one highlighted in yellow, Upper Now and Jonglei, is where IMA has been working with the World Bank to support health system strengthening work in those areas. Under the project we're working with World Bank is known as the Rapid Result Health Project, and we're working very closely in partnership with the Ministry of Health and 12 international and local partners, supporting 2 states, Upper Nile and Jonglei, and 24 counties in those states. Thank you, Matt.
Thank you, Theresa. Now I want to get into a little more of the discussion around strengthening health systems in the developing world, and specifically the role of faith-based organizations when it comes to creating and sustaining health systems. And one thing that strikes me, Tonny, Tumwesigye, is that the faith community plays a rather unique role in providing health services, and one thing I'm struck by is the sheer scale and magnitude by which Christian health associations and organizations like yours at the Uganda Protestant Medical Bureau provide to thousands and thousands of people. Do you see that trend increasing or decreasing?
Thank you, Matt. I think looking at the history of Uganda, we have been around for some time, and our hospitals are some of the first hospitals to offer care in Uganda. We've built a level of trust amongst the population to such a point that we are now integrated within the national health system. And also, just as Chuck, 80% of our network is rural, basically serving the vulnerable and the poor. And looking at the way the system in Uganda has been established, no one wants to go and serve these rural communities. And so by virtue of the way we've been established, I can only say that we can only grow because one, the population in these areas that we serve are also growing at rates that are just unsustainable. And that's one of the reasons why Uganda Protestant Medical Bureau is now involved in family planning as one of our core activities. And here we are seeing ourselves strengthening the systems through ensuring that the unmet need is done away with, but also ensuring that commodities are available to these communities. Commodities in terms of family planning commodities, both modern and rather natural methods. So by way of where we've been established and by way of how the network is scattered, our network can only grow because the populations that we are serving that are vulnerable are growing. And also by way of how we've structured ourselves to servicing the vulnerable for the future, we can only continue serving this population. So unless these populations really are going to be done away with, which is something that we see being far-fetched, we are looking at ensuring that the communities access care and that universal health coverage can be provided in our country. So Matt, I would comfortably say that nobody wants to serve the vulnerable, as the church has been, because evidence has shown that. Also, the government is not investing much in that area, so it can only be us who have basically planned to do that, who can do this kind of work. And that's why we need all the support to basically take the services to 80% of the Ugandan population. Thank you.
Thank you. And Peter Yeboah, from your perspective in Accra with the Christian Health Association of Ghana, have you seen a similar evolution of service provision within the last, I don't know, 10 to 15 years? And if so, does a lot of what Tonny says resonate with you as well?
Yeah, absolutely. If you assess the role of CHAG, maybe as the frontline feed-based organizations that is primarily set up for health service delivery, we have a lot. I mean, we provide. I mean, we have lots of functional, role in the healthcare system. As has been pointed out, because we believe primarily in equity, in social justice and inclusion. That is part of our mission anyway. Therefore, we are always exploring ways and means of ensuring universal health coverage across the broad spectrum of the society. And therefore, we would always say that CHAG, in many ways, we serve as pioneers, engineers, and innovators of the health system through several high-impact health system initiatives. For instance, way back in the 1990s, realizing that there was financial barrier to health services, CHAG facilities, two of them, pioneered and piloted a community-based health insurance scheme. And after piloting for about 6-7 years, it was adopted as a national health insurance scheme by the government. And by this particular intervention, many people, now you're aware that about 90% of people attending OPDs in Ghana are holding national health insurance card. And that in itself, indeed, resonated that we have been able to provide access to universal health coverage to all Ghanaians indirectly through the initiatives we had way back in the 90s that have been adopted. So in health financing, we have been there. Secondly, CHAG, earlier on in the 1980s, we were highly involved in community outreach programs. and then we were going on outreach, providing services, moving away from from stationary type of health services to mobile clinics. Come the 90s, government adopted this in the 2000s as a strategy of improving access, and that is called CHIPS. CHIPS is simply community-based health planning and services. That is now a strategic tool where in the remotest areas in Ghana, the government is building small compounds where a healthcare professional will be located there. In many ways, CHAG has been a pioneer, a strong promoter of universal health coverage to all manner of people. Secondly, for us, we always believe in health system resilience and sustainability, irrespective of the circumstances that we have. Because we are located primarily in the rural areas, anytime there's a national strike action, when there's a deadlock in negotiations between government and labor, leading to strike action, closure of hospitals and the rest, we ensure that all our member institutions provide 24-hour services, all because we are committed to health system resilience. When there's disease outbreak, HIV, AIDS, Ebola outbreak and the rest, we are always there. And we don't only see this as our core value, we also ensure that we always have constant formation and orientation of our health workforce so that they will be connected to the people we serve. Community orientation is what we are well noted for. And in all our advocacy, we are always seeing ourselves as the moral conscience of the health system. And that is why we always demonstrate our commitment to the poor and marginalized by citing our facilities in the remotest areas of Ghana, where we find that certain places in the cities are also deprived, the slums and the rest. We locate facilities there because we are also experiencing what's called urban poverty, where people located in the cities are neglected. So we are always serving as a moral conscience of the health system, promoting social justice and equity. And we are always thinking that indeed maintenance of partnership is indispensable if you want to ensure that the health system is well engaged for the benefit of the people.
Peter, thank you for that, and apologize, your audio dropped out there at the end.
We have constant mechanisms for engaging the government at all times by maintaining partnerships, by ensuring that we also have our fair share of the national health resources in such a way that we have an MOU with the government of Ghana. Yes. Hello.
Yes, thank you. Yes, Peter, thank you. I'm sorry,
Hello?
your audio dropped out in the middle. Yes.
Hello, am I online?
You are online.
Hello.
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 Peter, I'm sorry, your audio dropped out there in the middle, but Theresa, it sounds a little bit like what both of our colleagues from the Christian Health Associations and the faith-based organizations are talking about and building to is really this idea of partnership and expanding partnership. Is that something that you can corroborate? Is that something that you see from your perspective here at IMA, where we're working with a variety of Christian health associations?
Thank you, Matt. No, absolutely. I see that from where we're working with, from IMA World Health perspective, and we're working with our colleagues, the Christian Health Associations. And I'm really glad to hear that, one of the points that they've emphasized as the role of FBOs in health system strengthen is their health service delivery. I think they're doing a large scope of work with regards to the different services of a primary healthcare package that you're providing in the unserved and hard to reach areas. I think I just want to build upon that point and also highlight some of the areas that faith-based organizations, particularly IMA World Health, is working to strengthen systems in DRC and South Sudan. So we're working, I could say, so across the 6 pillars, same thing as my colleague said on health service delivery, supporting the provision of a of primary healthcare packages at health service delivery points. In addition to that, we're working also on strengthening health information systems, where we have supported the rollout of DHIS2 platform as the main health management information system in DRC, and that is been very helpful in terms of data processes and data management for health in DRC. I think one pillar as well that IMA is working closely with the Ministry of Health is Human Resources for Health, and both in DRC and South Sudan, where, for example, in DRC, we've implemented a variety of initiatives, including a payroll cleanup, which has provided efficiencies in managing health workers. And in South Sudan, we did something similar, but it was mostly focusing on harmonization of salaries of health workers, where there was a lot of imbalance, in just harmonizing salaries also increased the efficiencies of healthcare workers for the government. We're also doing a lot of work under leadership and governance. In South Sudan, out of the 24 counties that we are supporting, in 5 of them, we're working very closely with them to build their capacity to they're actually leading the implementation of all the activities and overseeing activities in those counties. I also want to talk about the financing aspect and the health system strengthening in South Sudan, particularly with the work that we're doing with county health departments. We are working through a performance-based contracting where there are incentives that are provided to the county health departments based on targets, performance targets. If they meet them, then they receive those incentives periodically. And then I think, as my other colleagues mentioned, there's a lot of work being done around medicines and medical supplies and strengthening supply chains. And in DRC, we're working very closely with the ministry to strengthen the supply chain management systems and making sure medicines and supplies are provided to health services at the right time. Thank you.
So, Tonny Tumwesigye, in Uganda, one thing that strikes me about what Theresa just said is that there seem to be a lot of factors that undergird the idea of providing health systems or healthcare to a broad range of the population, and a lot of that stuff isn't things that most folks would think about. Things like human resources for health, things like information systems. Can you talk to us a little bit about the challenges that you've faced specifically in Kampala with the Uganda Protestant Medical Bureau and around those sort of backbone, if you will, items like information management, human resources that have a direct impact on service provision, even though one might not immediately think about them?
Yes, Matt. Just as I mentioned, 80% of our network is rural, and as Peter was saying, we also have the peri-urban and the urban poor areas that we have facilities in. And under the work that we do, as Theresa just mentioned, we focus our work on the 6 building blocks of health care as defined by World Health Organization. And under those areas, we focus on strengthening each one of them, because we've realized that each plays a critical role in service delivery. For example, the work that we do on governance and leadership, we are keen to ensure that the church leadership and the hospital leadership is equipped with the skills and knowledge in managing these health facilities. Because without governance, rather without ownership of these facilities and ensuring that they plan for these facilities, then it becomes very difficult for the facilities to give the service. So we do governance training for the board of governors or board of directors for these hospitals, and the health unit management committees. We are able to train them and provide them the tools to, one, monitor themselves, but also monitor the health facilities in terms of income and expenditure and planning for these health facilities. Just like CHAG, we are involved in health financing, especially community-based health financing. We've piloted this in some of our hospitals, and already many of these hospitals are breaking even under the community health financing mechanism. And we are looking forward to having community-based health financing as part of the national health financing system through the National Health Insurance Scheme that soon will become law. So we piloted this through in the rural setup, and it has worked very well, because one of the critical arguments is that the rural poor are not able to pool resources amongst themselves. But we've demonstrated that this is very possible, that even people who are living below $1 a day are able to save up to $3 for a year's premium for their families. And that once this is done and these resources are pulled together, they are able to access quality health services in the rural hospitals. So this we are doing, and we are trying to put this to scale across the UPMB network. Again, the other area that we are looking at is through policy development, because here we see that as the government of Uganda, through the Ministry of Health, develops policies, we are part of this process, because many times we saw in the past was that policies that were being developed were in a way detrimental to the services that our facilities are offering. So we are on the table through the technical working groups and also the Health Policy Advisory Committee at the Ministry of Health to ensure that the policies that are developed in Uganda are basically favorable to all providing for us to be part of the process. And such policies involve the government providing resources, financial resources, to our health facilities, especially those that are not able to generate enough income to provide care for the people that they serve. And here we've been able to cause government to put aside resources to our health facilities. Again, through resilience and sustainability, as Peter has mentioned, we noted that many of our hospitals and health centers were having challenges with medicines. And here what we did was to come into partnership with our colleagues, the Uganda Catholic Medical Bureau, to establish the Joint Medical Store. This is our medicines and medical supplies arm that basically manages, procures, manages and transports medicines to our rural facilities. And through this mechanism, our facilities are able to buy quality medicines through a system, again, that has been tested and that has provided quality drugs. An example here that has shown our resilience here is that through the national system, we've seen challenges with procuring of quality drugs. But because Joint Medical Stores has this as the backbone, as quality as the backbone to the medicines that they send out, we've had no problem at all with all the products that our facilities are able to access. Of course, the other area that we've strongly ensured our participation is through the HIV epidemic that Uganda was faced with. Of course, now it's standing at about 7%, all the way from about 30%. The Uganda Protestant Medical Bureau has been at the forefront of ensuring that we are able to recruit staff in our facilities who are able to respond to some of these epidemics. Of course, the challenge for Human Resources for Health, notwithstanding, is that our facilities, considering where they are, find it very difficult to attract and retain human resources for health. Because many of the nurses and the doctors would not wish to work in some of those places. So through our work, we've been able to provide incentives some of these cadres, looking at the doctors, for example. We've been able to create situations in the rural setup where these doctors are able to go and work. For example, we give scholarships, and these scholarships are able to train health workers and doctors, and then we are able to bond them to work in these rural areas. But also we've incentivized their stay in these rural areas through providing them with accommodation, relatively good accommodation with electricity, internet connection, water, and providing them with IT, continuous professional development. I mean, they are there, but they are able to access training, online training, so that they don't have to come to Kampala. So under the human HMIS, we've undertaken strengthening of our facilities through ensuring that they're able to report into the national health system. So all our hospitals would have, we've installed internet, computers, but also they are able, we've trained them to capture data and input data into the national health system. And also we've been able to train what we call the diocesan health coordinators. These are persons who coordinate health facilities within their jurisdiction under a particular church. So all diocesan health bodies have been equipped with ICT materials, and the diocesan health coordinators have been trained also to input data of the lower level health facilities. So this way, a health facility over 500 kilometers away is able to input data into the national system through their diocesan health coordinators. And this mechanism, we've been able to ensure that they have internet, modems, and that this is an ongoing process. So, for example, if we wanted data today for OPD attendance for the previous month, we just go into the system, and these nurses are able to input into the same system, and we're able to generate such data without significant problems. So this is basically some of the things that we are doing to ensure that that under the HMIS we are reporting on time within the national mechanism, but also we've been able to recruit staff as UPMB and second those staff to our health facilities. And through this we do, we monitor this staff through the electronic human resource information management system. So hospitals are able to input data of all their staff, and when staff leave, we are able to track and monitor those that are leaving and those that are coming in, and we are able to also assess those staff performance, whether they've been appraised, because all this is done electronically. So this is basically what we are involved in addition to the community work that we do.
Thank you. Thank you, Tonny. I appreciate you you giving us insight from your perspective. That was Tonny Tumwesigye of the Uganda Protestant Medical Bureau. We're also joined by Peter Yeboah of the Christian Health Association of Ghana, and Theresa Nyamupachitu here at IMA World Health in Washington, D.C. I'm Matt Hackworth, and just a reminder, we will take your questions here in about 10 minutes. You can ask your questions using the GoToMeeting or GoToWebinar rather chat function or questions panel located in your GoToWebinar control panel at the right of your screen. We've touched on this a little bit, but Peter, I want to come to you next and talk a little bit about best practices to build upon. What are some key best practices that you look for from your perspective in leadership at the Christian Health Association of Ghana, especially when it comes to partnership? What do you consider to be a core tenet of partnership and a way to make partnership work, and not only on a functional level, but to help it thrive?
Yes, thank you very much. We the Christian Health Association of Ghana have always felt that of all the 9 health system building blocks, by the way, we are adopting the 9 health system building blocks consistent with this Bamako declaration thing. We've always identified leadership and governance as an important thread that runs through all the blocks, that if you want to ensure effective, quality, affordable, and accessible service delivery, the pathway is leadership and governance. We have noted that within the network, we are challenged by inadequate leadership and management skills. We've also observed weak governance systems, accountability and transparency issues. We also observe that most of our church health facilities, beyond our faiths, when it comes to regulatory compliance, we are selectively, we observe selective compliance to policies and guidelines from the Ministry of Health. We are seeing challenges in organizational development, institutional strengthening capacity, and then generally non-compliance issues. So what CHAG has done, first from the national level, is to have a system of building capacity of all our denominational groupings, our hospitals, health centers, and the rest, because we see that most of our managers do not really have management skills, and the capacity to engage actors and players in the health system were really challenged. So CHAG has signed an MOU with the Ministry of Health, and then also that of the Ghana Health Service. And the importance of this MOU is that it provides us the framework where we are able to negotiate for an equitable allocation of health resources for CHAG members. The MOU, which was signed, or which has been signed with the Ministry of Health and the Ghana Health Service, enables us to have joint quarterly meetings to monitor progress of our partnerships in the health system. Because of that, government pays about 80% of the salaries of our staff, and that enhances the sustainability of our health system. Beyond that, we are also able to negotiate for equitable allocation of clinical personnel, health personnel. We are able to use our data, our service output data. We are able to play advocacy, lobbying, and negotiation within the framework of our partnership to have what is due. Of course, there are challenges there. We are observing some form of latent competition between church health facilities and government facilities in the rural areas. Nonetheless, because of our focus on partnership, we are able to negotiate, lobby, play advocacy with the government at all times. That ensures that our position and place within the health system is really well guaranteed. With respect to health information, we are unfortunately observing that most Christian health associations are interested in submitting data, health output data to government machinery, but the ability to use the data for decision making is always lacking. Using the data, to determine service coverage, to determine issues of financial sustainability, and many other things. So CHAG is building capacity. We have been building capacity of all our staff, of all our denominational groupings and health facilities to ensure that we are able to leverage data for decision making. With respect to health commodities, health technologies, we have observed that because our national health insurance scheme is bedeviled or is having challenges, financial sustainability challenges, even though it's manageable, we are seeing most of our facilities becoming vulnerable to fake medicines, substandard medicines, and counterfeit medicines because they are not reimbursed on time. So they have been sourcing medicines from the open market whose quality we can't guarantee. So we have been supporting one of our denominational groupings, the National Academic Health Service, to establish what is called pool procurement system that ensure that they do bulk purchasing, framework contracting. And after about 3 to 5 years, we've observed that once you engage in pool procurement, you are able to reduce the costs of procurement to about 35%. And I think that is an important input in considerations of financial sustainability, efficiency, effectiveness in managing the health system. So generally with CHAG, we think that leadership and governance partnership is very, very important. And one other critical area that we are also observing is engagement with the community. Engagement with the community. We had some projects, about 20 hospitals, that were experiencing significant drops in OPD attendance. And the refrain was, oh, we think that probably government is establishing hospitals all around. But then when we engage them, they engage the community, they realize that the attitude of staff was to be blamed. There was change of orientation. Our brand of compassionate care was really going down. And we said that our clients are no longer passive recipients of our services. They are indeed active consumers, making intelligent choices. And in fact, our National Health Insurance Scheme has even given power to patients because they are doing what's called capitation. And that capitation, your clients must choose you, register with you for 6 months. Because of that, once we build the capacity of hospitals, engagement, and the rest, OPD attendance recovered, and it even increased to 30%. So broadly, when we harmonize all the building blocks within the building blocks of the health system, and we focus on leadership and governance as an important thread of all the building blocks and the rest, our mission of improving access, providing universal health coverage, efficient one, will definitely be achieved. And the experience of CHAG is evident enough to show that when leadership assumes its rightful place, our clients, our patients have access to quality, affordable, accessible, and available health services.
Thank you, Peter Yeboah of the Christian Health Association of Ghana. I want to ask my colleague Theresa Nyamupachitu in her role with IMA World Health and working with the Christian Health Associations. We've mentioned a little bit about formal agreements with ministries of health and formal agreements with other unilateral, multilateral donors. I'm wondering about agreements and partnerships within the faith community and what that brings to bear when it comes to strengthening health systems.
Okay, thank you, Matt. So I think one of the unique things that our health system strengthening approach brings either in DRC or South Sudan, or as we work with Christian health associations, is we bring in some faith principles. We do have a faith component within our health system strengthening approaches, and two key areas or two key faith principles that we really build in and integrate into our approach is treating partnerships, or everyone in the partnership, as equal parts, as equal members, that that come together and bring people together to have an open dialogue and to share issues and come up with solutions that work for everyone. And so, for example, where we have worked, we have been a convener of many of discussions, or facilitated a lot of discussions with different partners in the country. So bringing together Ministry of Health, bringing together to meet with the private sector, to meet with academic institutions, as well as both non-faith-based organizations and faith-based organizations. So I think that's really a core faith principle that we bring together, that we tap into. I think another element, also a faith principle that we bring into the health system strengthening approach, is keeping an eye on serving the most vulnerable. I think this is a key element of faith, where we want to make sure the most vulnerable populations are well served, they get equal health care. And so in our approach, we're always thinking of serving the last mile. Are all the activities that we're doing benefiting the last mile, reaching to where they are most needed and to the populations that most need them? Thank you.
Thank you. And Tonny Tumwesigye, I was wondering if Theresa's missive about not only the role of faith-based organizations and the scope and ability to touch individuals, but also the commitment that faith-based organizations have to serving the most vulnerable. Is that something in your role leading the Uganda Protestant Medical Bureau that isn't lost on a Ministry of Health, let's say? Do your when you interact with the Ministry of Health or another government agency, do they really understand the nature of the faith-based organization and its role in serving the most vulnerable?
Yes, Matt. The Ministry of Health fully understands the role that faith organizations provide in Uganda, and through our partnership and engagement, again, we have a memorandum of understanding with the Ministry of Health, and which was signed all the way in 1997, at the time when the government recognized that without the faith and groups in Uganda, healthcare in Uganda would be a significant challenge. But also the history of Uganda, as you know, we went through an era of dictatorship through the Idi Amin era, and the health system in Uganda virtually collapsed. And it is the faith network in Uganda that basically held health services in Uganda. It is hospitals and clinics that continue to offer care when all the public health facilities virtually closed and all people virtually went into exile. So over the years, the government has recognized this role that faith groups provide, and that's why in our sector, in the health sector in Uganda, the government through the Ministry of Health has recognized this role and has provided for the private and for-profit sector, the faith groups, to be part of the decision-making body in the country. So we sign a compact like all other health development partners in Uganda, and we are on the Health Policy Advisory Committee. But just as my colleague has mentioned, because I've already mentioned, is that we think partnership is very critical, and but also not only with the public sector or other partners that don't have the same faith as yourselves, but also within different faiths. For example, in our view, we think partnership is about having a common interest, common goal, but also recognizing that that the need is huge, and that one group cannot solve the entire problem, that you need everybody. So it's about respect and others knowing that you're bringing on table something that they may not be able to bring. I'll give you an example. When at the peak or the climax of our HIV epidemic, it was recognized that faith was very critical, and that without faith, organizations coming on the table, it was going to be very difficult to bring down the HIV epidemic in Uganda. And it's at a time when the faith groups were brought on board that we began to see a change and a change in the epidemic in the country. But also, for example, it was noted that within the health system, that medicines and medical supplies are one of those huge challenges that the country faces. And so by establishing the joint medical stores, through which is a faith component, the government of Uganda has undertaken to support it and appreciate that actually you cannot manage medical supplies in one angle. You need another another backup. We need a backup, and our store has been seen as backup to national health systems. That the country can also rely on the joint medical stores to supply medicines just in case the national medical stores is having challenges. And through the African Christian Health Association platform that Theresa mentioned, we are working with similar organizations, specifically CHAC in Kenya, where our medical stores together with CHAC are working together on pool on pool procurement, just as Peter has mentioned. So we are leveraging on different countries, importing medicines from, say, India, especially those medicines that we cannot produce in Uganda, and bulk purchasing them and then sharing them within different countries. And so within such a mechanism, we think that we should be able to bring down the costs for medicines, because as you know, costs for quality medicines are a little bit higher. And so the partnership here is within UPMB and UCMB, within the in-country partnership, but also across different countries coming together. And we are leveraging on the expertise of the Ecumenical Pharmaceutical Network, which is then looking at a broader faith component in terms of pharmaceuticals. So to me, I think partnership is broader, it is bigger, it is paramount, that you need partnership across the faith, but also partnership across different organizations that don't believe, don't have the same faith, but believe in the common goal. Of course, the other partnership, you may want to look at it, for example, with the U.S. government through Centers for Disease Control or through the USAID that are providing resources for the poor, but also for marginalized communities. And for us as faith, we are able to leverage or tap into those resources. So we think that yes, partnership is broader than just interfaith. We think we can go further to also involve those that are of non-faith but have the resources to serve the people that we are serving.
Thank you,
so
Tonny.
yes, partnership is very important.
Thank you. I want to go on and turn to question and answers from the audience now. If you have a question, type it into the chat panel on your GoToMeeting control panel. I want to turn to a question from Jean, who wonders, Theresa Nyamupachitu, this might be for you. She wonders what the incentives are for county health departments who meet their targets. Are they financial incentives? Is it improvements to clinics, certificates, that sort of thing?
Thanks, Matt, and thank you for that question. So the incentives that we provide in South Sudan to community health departments are grants. So these are actually monetary grants that are provided on a monthly basis. They're based on achievement of certain quantitative primary healthcare indicators, such as the number of measles vaccinations, the number of curative consultations for children under 5. And from our experience, what we have seen is these county health departments then use these grants for infrastructural improvements of health facilities, like renovations that they need to make on the actual buildings themselves. We've also seen them using them to purchase things like motorcycles, to help with the transportation of health workers. And also some have used for salary top-up of health workers, which I actually think has been a good strategy in incentivizing the health workers to maintain those performance targets.
Thank you for that. I also want to turn to a question now from Michelle, who is wondering, Tonny, from you. You referenced high turnover of physicians. And to the others on the panel, Peter, Tonny, Theresa, there also seems to be sometimes high turnover of partners. What do you all do to address that? Is there any sort of magic component that would commit a partner into a more longer-term effective relationship and prevent some of the turnover among key partnerships?
Yes, so thank you, Matt. I think what we are doing is to make sure that we as much as possible meet our partners' needs. And one way we've done that, I mean, for example, as UPMB, we've not seen a significant high turnover of partners. We have partners that we've been with for over 20, 30 years, and they have grown. And the whole aim for this is to make sure that our work is clear, what our roles are, and that we are meeting the targets that our partners have set. And I think to us that's one of the critical ways. And of course, we've seen a change in the way partners have been working with us. Of course, initially they were institutional partners, but now we've moved into performance-based financing. We are also ensuring that our work, we set our targets, and our targets are within a certain period. It is within it's within our strategic plan. It's within our annual work plans, and that there is a clear outputs for the work that we are doing. Unlike in the past, where it was activity-based work that we're doing. So it's all about ensuring that we are doing what we are supposed to do. Accountability for the resources that we are given. That is all clear. And all these we've put in place, and we've seen our partners continue to work with us.
Thank you, Tonny. I appreciate that, and we'll unfortunately have to leave it there for now. I regret that we didn't get to all of the questions, but I think a long list of questions is a sign of a great discussion, and hopefully we'll have more to come. Thanks to our guest, Peter Yeboah of the Christian Health Association of Ghana and Accra, Tonny Tumwesigye of the Uganda Protestant Medical Bureau, and my colleague Theresa Nyamupachitu of IMA World Health. We will send a follow-up survey and also an email regarding the recording availability sometime in the next week. My special thanks to Christian Connections for International Health and being a co-sponsor of this endeavor. I'm Matt Hackworth with IMA World Health. Thanks for joining us. Have a good day.
Thank you, Matt. Bye.
Bye-bye.